All right, we have a full agenda today, so we're going to go ahead and get started, and we'll welcome all those that are joining us in the minutes ahead as well. So, as a reminder, our agenda that was shared online, we have a lot to squeeze in today. I'm really looking forward to this time as a group, as we were not able to meet in February due to an unexpected snowstorm closing our state offices up here in Reno. So, excited to cover a few of those items that we had planned to in the original February agenda. And then we have a few additions specific to our March meeting related to our family peer support, home and community-based benefit as well. So with that, we'll get started as always with our roll call to ensure we have quorum of working group representatives. So Matt, are you here? Seeing a few folks come off mute, so come interrupt me if I've missed you, but I'm gonna keep moving. Leah?
Yes, I'm here.
Wonderful, welcome Leah. Lanisha,
This is Matt Lehman, I am here.
Oh,
this is Matt
welcome,
Lehman, I am here.
Perfect, thank you. I thought I saw your name, sounds good. Lanisha, are you here? I think she will be joining us momentarily. JD, I see you.
I'm here.
Welcome, glad to have you. I'm not sure if Devin is able to attend. Devin, are you here? Okay, I do believe Annalicia will be able to join us with her school schedule today. Annalicia, have you been able to join yet? Oh, I think she'll be logging on from her after school activity shortly, but looking forward to having her on. And Luke, are you here?
I'm here.
Wonderful, glad to have you. How about Alana?
I'm here.
Welcome. Dave?
Good afternoon, present.
Thanks, Dave. How about Dr. McGrew?
I'm here.
Great. Dr. Freeman?
I'm here.
Welcome. Dr. Cooper?
I'm here.
Welcome. Glenda?
Glenda actually is not going to be here today. She has an emergency.
Oh, I'm sorry to hear. Thank you, DJ, for letting me know.
You're
Great.
welcome.
Natalie?
Here.
Wonderful. Stephanie? Okay, we'll come back to Stephanie. And Janelle?
I'm here. Sorry about that.
No worries. Welcome, Janelle. All right. Moving forward, Angie, are you here? All right. Hopefully Angie will join us shortly. Calling out that our rural health center representative is actually an open slot at this time. I'm really looking forward to, we're having some conversations at our upcoming tribal consultation to solicit some more applicants for this slot. So more to come on that front. How about Gwyneth?
Good afternoon, present.
Welcome. And Jessica?
I'm here.
Great. Myambi?
Good afternoon. I am here.
Perfect. I thought I saw you join. Okay, great to have you. And Shayla?
I am present.
Wonderful. Glad to have you, Shayla. And our final slide, our community partners. I believe Bree is on spring break this week, unless she is joining us. Okay, I'm seeing a nod from DJ. Karen?
Good afternoon, Karen Tacher.
Welcome, Karen. And Robin? Okay, we'll come back to Robin. And Jonathan? Okay, and Santosha?
Present.
Wonderful. Thank you, Santosha. All right, we do have quorum, so we're going to continue to move forward. But for working group members that are joining us later, please just drop your name in the chat so we can make sure we'll keep an eye on the attendee list so we can capture that as well. So thank you all for taking the time. And as always, for spending your afternoon with us. I know it is quite a busy time of year, and now that the sun is out, there are many places we would like to be. So thank you for spending this time with us. So with that, I'm really excited to turn it over to our team at the Department of Justice. So as we shared in our January meeting, our settlement agreement was reached in January. As we kind of walked through each of it, we thought it'd be really important for you all to meet the folks that are our partners in this work and worked with the Nevada team throughout the course of that settlement negotiation. So I believe Beth Kurtz is here to join us. Beth, I'll turn it over to you to introduce yourself and share a little bit more about the team.
Great. Awesome. Thanks, Anne. Thanks for having us. And thanks to everyone on the call for being a part of this group and for all of the work that you do. You know, it's been a long journey. I've been meeting with folks in Nevada to talk about these important issues for over 4 years now. And so it's really great to see folks who have been a part of that journey, as well as some of your colleagues, and to meet some of you. We're really happy to be here, and we're really happy to be partnering with the state government on this important effort. The settlement agreement is, as I know many of you know, is designed as a remedy to the violations of the Americans with Disabilities Act that we found and issued in a public report from October 2022. Obviously, some things have changed since then, and these efforts will be underway according to a timeline that the state has worked on to kind of try to roll out the efforts to comply with this agreement. And I know Anne has presented to this group a bunch about that. I won't go into a ton of detail about the settlement agreement because I understand that you all have kind of gone through it and that this group and other groups are sort of diving in. I know we'll talk tonight about some of the issues, the home and community-based services as part of the agreement. Essentially, the agreement is designed to allow children with behavioral health disabilities to remain in their homes and communities and in family-like settings. That includes biological family, kinship families, foster families, and families of all kinds and all definitions. And to avoid, when possible, unnecessary use of hospitals and residential treatment facilities. I know you all know that some of those facilities are tough places to be, places kids may not want to be for a while, and some of them are quite far away. So the agreement requires building out crisis services, wraparound services, and a sort of package of what we call intensive in-home services to help support and meet the needs of kids and families. So all of this is exciting work. Really appreciate, I would say, the ongoing commitment to this work that you all demonstrate, the patience, the sort of methodical approach, the thoughtfulness that you put into it, and the passion that you all have behind it, because we all know you all are the parents of kids, or you are who have experienced challenges with the behavioral health system. Maybe you have experienced challenges with the behavioral health system, or maybe you work with clients or others as part of your professional life that interact with these systems that are often really tough for kids and families. So we're here. I am in DC right now, but we are here over Teams, though hope to get out to Nevada again in the not too distant future, though I can't say exactly when, we'll see. But Haley, who's the other attorney on this team, and I are around. We also have Dana, who's a paralegal in our office, an investigator in our office, excuse me, who's going to be working with us on this. And, happy to answer questions that folks have as we move forward in this partnership. Happy to have people reach out anytime. I can put my email in the chat. We just continue to be here and are really grateful for all of the leadership from the Department of Health and Human Services and the Department of Healthcare Finance and Policy on all these important implementation efforts. And then actually, before I wrap, and I will turn it back to you, Anne, in a second, the other thing I wanted to highlight is the onboarding of the independent reviewer. So this is a sort of national expert in these issues who is here to provide support for implementation of the settlement, to provide technical assistance to the state, and to prepare compliance reports. They are not here tonight, but hope to be on this call and on other calls and meeting with you all soon. So in addition to DOJ remaining a reference, and in addition to the state being so thoughtful and open to all of your feedback, the independent reviewer team will also be around. So hopefully that wealth of support for this important project will be an asset to it.
Wonderful. Well, thank you, Beth. I appreciate that warm introduction and excited to see all this team really take shape and kind of come together and as we move into the implementation phase of this work. So thank you again to you and your team for your partnership, and also look forward to introducing our independent review team to this group beginning hopefully in our April meeting. So more to come, new faces to come as well, but really thankful for everyone's support and partnership in this effort. So with that, we'll move into our next agenda item, which is follow-ups from our January working group, which I know feels like a while ago. One really important piece of feedback we got from you all is that this hour goes quickly, and we want to find a way to both prepare our working group and representatives for the discussion, and also to ensure that we're documenting all the feedback that we get from you all and really tracking our progress towards addressing those month over month. So a few updates that and changes to our process that we made since January. First is that we're creating a feedback summary process. And so what you'll see on our website posted right now is that we have feedback from our October and December and January working group meetings documented here. This is anonymized feedback, so there's no names listed, but everything that has been shared with us, either from our representatives or in a public comment forum, should in some form or fashion be represented here, really showing what we're hearing from you in these kind of groups or kind of themes, and then our update on what we're doing about it so far. We recognize we cannot solve most of these challenges within a month, but we want to show you what steps that we're taking and what the progress that we have made and will continue to make over time. So this is a running document that's available on our website now, and it will be updated monthly after each of our working group meetings. We're also planning to develop a frequently asked questions document in an effort to really answer a lot of the common questions or themes that we're getting, particularly as our new benefits and delivery system go live. It's a really helpful format for us to start collating a lot of that information. So as always, welcome your feedback if this is useful to you all or if there's other ways to do it, but want to thank you for that feedback in terms of documenting, as well as, and you'll notice that we shared in our email ahead of time regarding the pre-read document on our PRTF quality incentive payment. For those that have a chance to read it, I hope that will then kind of support you in contributing to our discussion and later in this meeting. And as always, we will continue to share those resources ahead of time as they're relevant. So keep that feedback coming, and we're going to continue to try to tweak and ensure this forum is as useful as possible while really respecting your time and the time that you take to be part of this. We are really grateful and appreciative of that. So the final update on the process side before we dive into the more interesting content is that we're really excited to launch what we're calling a co-chair role. So this will be a current working group representative who is selected by their peers to serve as a co-chair for the next 7 months of the year, from May to December of 2025. This is really our effort to bring our representatives even closer to our process to create the agenda and discussion questions and essentially the ways that we create this forum to be useful. We want it to really reflect what the working group representatives have in mind, and so we're seeking a co-chair to support us in that effort. It's hopefully a relatively lightweight additional commitment, just a 1-hour virtual meeting each month to help think through the preparations for the subsequent agendas for the upcoming 2 months and provide any initial feedback or kind of sneak preview feedback on our content as well. So this will be new for us, and we're seeking your nominations either of yourself or of a peer. Again, our working group representatives are listed in those first slides here and posted on our website. So please send those via email to us at our Children's Behavioral Health email by the end of day next Friday, March 21st. And we will have a form for representatives to vote on this co-chair during our April meeting. So happy to answer any questions and welcome your feedback, or as you're contemplating whether you'd like to serve in this role, don't hesitate to reach out to us, but we'd be really eager to work with you and appreciative of your willingness to consider taking on this role at least through the end of this year. So with that, we'll move into our first of 2 main content agenda items here, and that is diving into section 5 of our settlement agreement, which is the home and community-based services summary. So I know our January meeting flew by. It was a very long and quick overview of each section. And so we want to spend time in each of our upcoming meetings really honing in on a particular area. And today we want to talk about, at a 10,000-foot view, what do our home and community-based services look like as defined by the settlement agreement? And I want to start by really taking some time on the definitions. I know that's not always the most fun way to spend our time, but it's really crucial that we're all using the same terms and phrases to talk about what we're really developing as services here. And the settlement agreement is very specific in that language, and we're going to talk about it. So this is how the settlement agreement that we have with the Department of Justice defines behavioral health services. So that oblong, darker blue circle is representative of all behavioral health services. So those range, as we know, from earlier intervention, outpatient services, all the way through acute, inpatient, and residential services as well. Nested within that is a subsection defined by the settlement agreement as home and community-based services. And so that is inclusive of both intensive in-home services and mobile crisis and crisis stabilization. I want to call out for those that are have worked closely with our Medicaid world, the term home and community-based services is really familiar for those that are working with our waiver offerings. And so want to call out, this is a slightly different definition of that. It is still relevant, of course. These services are delivered at home and in the community, but it doesn't necessarily mean the same thing as an HCBS waiver program for those that are familiar with that. Really honing in even further is that green circle, which is defined by the settlement as our intensive in-home services. So these are the benefits that you're pretty familiar with, that we've talked about, that we are in the processes of developing. So those are wraparound facilitation, respite care, individual and family therapy, behavioral support services, and family and youth peer support. So this is kind of our nested eggs of kind of exactly what those different definitions mean. And I think what's important, though, is each of those actual benefits has a very specific definition in the agreement. So we've broken it out here for those that are interested. I know we shared our settlement agreement link below or in our January meeting. And Beth, if you'd be willing to drop in that public link again, I'd appreciate it, just so folks that may be curious can search this right now. But we've linked to you where those definitions can be found in the settlement, because it's really helpful for us to ground us in what does it actually mean when we say the term respite care or when we say the term intensive care coordination. The great news is we have a very clear answer in the agreement, and I want to give that kind of cheat sheet to you all to be able to reflect that. So moving from the settlement definitions into what does that mean in Nevada right now as of March 13th, 2025. Thank you, Beth, so much. This is what that looks like. So you'll see it's about half and half in terms of the benefits that are currently covered by Nevada Medicaid and the benefits that are under development. And I want to call out covered by Nevada Medicaid means that on this current day, Nevada Medicaid can reimburse providers who are delivering these services. We recognize that there are many providers, including folks on this very call, that are delivering the services considered under development right now, right? These services exist in our state today, and we're excited to continue to strengthen those provider networks and increase the availability of those services, but they are not currently reimbursable by Medicaid. And so that is what this slide is describing, which is how can we as a Medicaid program in our state secure the approval from the federal government to be able to start paying for those services as soon as possible. So I won't go through each and every detail of this timeline. You can see on the right here what that looks like. But the bottom line is that by the end of this year, by December 31st, our goal is that all of that will be green. And every one of these benefits will be reimbursable by Nevada Medicaid. And you'll see these kind of turned on in waves throughout the course of the year. What's important, of course, is that all of this is pending federal approval. So the Center for Medicare and Medicaid Services has to approve, CMS has to approve our ability as a state to cover these. And it ties back. We have very clear legal citations of where we're going to be justifying that they provide that approval. But that can take some time. And it's always a little bit of an unknown for those that have been around Medicaid for some time. We never quite know exactly when that approval will come through. So we are doing everything possible to submit those with as much time as possible for the federal government to review, but recognize that while things may, the ability for these to turn green finally will depend on that final CMS approval. So with that, I'm excited to dive a little bit more specifically into one of our benefits that we're working on turning green or turning on as a reimbursable benefit first, and that is our family peer support benefit. And before we talk all about the wonkiness of the policy and the details of how we're designing that reimbursement, I think it's really important that as a group, we have an understanding of what does the service actually mean for the youth in our state who are receiving it right now and for our families in the state that are receiving this, right? This is a family-to-family service that is offered by family-run organizations in our state. And I'm really honored that we have a representative from one of those leading organizations here in our working group. So Karen Tacher has generously agreed to share a little bit more about Nevada PEP, her organization, and the details of what family peer support means in the Nevada PEP context. We are really thankful to have been working with the Nevada PEP team to develop this benefit. I'm excited for them to kind of ground you in what that looks like right now, what that's looked like in Nevada over the past few decades, and then we'll share a little bit more about what that looks like as a Medicaid benefit. So Karen, I'll turn it over to you.
Thank you, Anne, and thank you for this opportunity. never turn away from an opportunity to talk about family peer support. So just a little history. Nevada PEP is a statewide family-run organization, this year celebrating our 30th anniversary. We've been providing family peer support for many years, and I have been engaged in the national movement to develop and promote family peer support since 1993. Nevada PEP was also a member of the group that worked to develop the National Certification for Family Peer Support Specialist in 2012. Our family peer support specialists are currently nationally certified. So what is family peer support? It's a strength-based service that connects parents or primary caregivers of children and youth with behavioral health care needs, including those with co-occurring IDD, to parents with lived experience. The service helps families feel less alone by decreasing isolation and helping the family develop natural supports. Family peer support enhances family and provider collaboration and communication by focusing on family-driven goals and celebrating accomplishments. This service decreases internalized blame and improves family confidence and self-efficacy. Family peer support empowers families to take an active role in their child's treatment, education. Research has shown that when families are engaged with service providers and they have a family peer support specialist on their team, they complete the plans and follow through at a higher rate. The service decreases stress, encourages self-care, and builds family resiliency. Family peer support specialists have been there. We know about resilience and recovery firsthand. Specialists listen with unique understanding. We help families identify their strengths and help families consider and communicate their concerns and desired outcomes. We specialize in connecting families with community resources and teach families how to navigate very complex systems. We are thrilled that family peer support will soon become a Medicaid service and that Nevada will have a state-level certification as part of this transformation. This will increase the family peer support workforce and give families expanded access to this valuable service. And that is the quickest overview I could do. And
It's wonderful. No, Karen, I appreciate it. I know it's challenging to distill decades of work into a short summary, but I think that's really helpful for us to hear a little bit more about Nevada PEP's work and really think about how that's connected to what that looks like in policy. So I have one more slide and then I'll open it up for discussion, and I welcome folks that have questions for Karen about the Nevada PEP model to ask those there as well. But as Karen mentioned, we've been doing a lot of work to figure out how do we translate the complexity and the beauty of what is family peer support as a service into something that is a reimbursable benefit within a Medicaid program. So you'll see us use this template a couple times in our presentation today, but there's 4 real core components of what makes up a Medicaid benefit. And those are in blue here. How do we define the benefit or the service? Secondly is who is allowed to provide the service? So provider qualifications. Third is reimbursement methodology. How do we pay for it? And then lastly is limitations. Are there any limitations on how recipients can access these services? So what you'll see in those, the white boxes are really the key questions that we need to answer in our policy. And the blue boxes are what those answers look like for family peer support in particular. So I know we shared our full family peer support policy draft with you all via email in the notice for this, as well as on our public notices page on the website. So you'll see this all reflected here, but we tried just to distill it into the real core components of this. So in terms of the benefit, the service itself, as Karen shared, it's a structured recovery-oriented support to parents and caregivers of children and youth with mental health or substance use disorders. In terms of eligibility, so which Medicaid recipients can access this, it's youth under the age of 21 with a diagnosed mental health or substance use disorder, and that youth must have family peer support as an identified kind of treatment path within their treatment plan. As Karen mentioned, certification, there's a national certification for family peer support specialists that her team has right now. We are developing what a Nevada Medicaid approved certification model looks like, and those that will enroll as providers will provide documentation of that upon enrollment with Medicaid. Reimbursement is done by billing for 15-minute units for that service, up to a total of 18 hours before prior authorization is required. So additional hours beyond that would require approval at that point. So that's the very high-level summary, and I welcome those to turn to the policy itself for a little bit more detail on each of these sections. But you'll see here how we try to translate, this is what the service means in our community, and here from a Medicaid perspective are the components that are required to really define what that looks like. So with that, I will pause. I know I just shared a lot of information, and I'll open it up to questions. First and foremost, do you have any questions on the benefits definitions we shared within the settlement agreement, or what that federal approval timeline summary looks like? And then secondly, what questions or feedback do you have on our family peer support policy itself? And any questions related to the service are welcome if Karen is willing to provide those as well. So yes, Tiffany, I see your question.
Thank you. And are you able to hear me?
Yes, I am.
Okay, perfect. Thank you so much. My name is Tiffany Curry, and I'm the owner and manager of L Equine in the Northern Nevada area. And I provide services that are untraditional for behavioral health needs. For example, youth in the foster care system that may not want to go to traditional therapy and wanting to do something a bit different. We use horses to do equine assisted learning. I'm curious if you guys have contemplated, adding something to that effect under the community-based services, or if you have another spot for that.
Thank you for your question, Tiffany, and it's lovely to meet you. I've heard wonderful things about the equine therapy model, and I appreciate you raising this. So at this time, our focus is really on the home and community-based services that are required for our settlement agreement. So that's kind of our first bar that we're required to meet, and we'll be spending the next year focused on that. Our interim finance committee approval has been focused on those benefits to date, and I'd welcome if Beth or anyone from the DOJ team wants to chime in about how those benefits were selected through the process. It's really reflective of what types of gaps were identified throughout the course of the investigation that Beth mentioned. However, I do recognize that there are other wonderful creative models of behavioral health support that may not be reflected here, and we will continue to consider those as additions to Medicaid benefits as we have both authority from the federal perspective and the funding to do so. So I appreciate you raising this and that will continue to keep us in mind. I know our behavioral health team has this on our radar, but at this point, to be able to cover it, we would need that authority from both the government, the federal government, and a budget perspective, and that we don't unfortunately have that for equine therapy at this time. Is that helpful answer to your question there?
Yes, thank you for articulating that, Anne. I appreciate you guys considering it for the future.
Of course, of course. Beth, is there anything that you'd like to add there on that piece?
No, I think you did a good job. I think the core of the services in the agreement are the sort of baseline, most evidence-based and most nationally popular and established services to be delivered to kids who are at risk of entering hospitalization and residential settings. But they're defined in a way that is flexible, that gives Nevada some room to develop a Nevada specific package in them, which the state is doing. But this is a remedy. This is sort of a legal civil rights settlement, which means that it is a floor and not a ceiling. So there's a lot of choices that any state policy, any state Medicaid and mental health agency would make and would be welcome to make that would be beyond the scope for me to comment on. So I think that this is a good example of something that is a policy discussion for all of you all to talk about that'll be beyond the scope of the four corners of the settlement.
Thank you, Beth.
Wonderful. Thank you. I'm seeing a few comments related to the family peer support policy in the chat here. Santosha sharing the fact that parents can access 18 hours of the service before prior authorization is required is great. Appreciate that feedback, Santosha. And Michelle, good question in terms of who decides that family peer support is on the treatment plan. That would be a behavioral health clinician. And our behavioral health policy team can keep me honest in terms of how we're defining that in the policy itself. It should be in that language, but it would be ideally the provider that youth and family are already working with. That's a requirement from our Medicaid program regulation side that treatment plan piece is included. Yeah, Luke, asking, please share a little bit more about training requirements for peer support specialists, specifically around communication skills. And Karen, I don't mean to put you on the spot, but I would welcome if you have anything to share. Karen's organization has been leading a lot of training efforts in the state, and I'd love for you to share a little more details if you're willing.
So I'm not sure if the question is about family peer support or peer-to-peer support. But with family peer support, extensive training occurs, and the specialists have to meet core competencies that include communication and engagement strategies. And I also wanted to just bring up, I think the policy says 26 hours, which the one that was attached.
Thank you. Oh, thank you, Karen. Yeah, let me double check that. I know that had gone back and forth a few times in our discussion. So we will make sure that is very clear moving forward. I appreciate it. And Luke, please let us know if that answers your question as well around the communication skills. And Karen, I know that the training that you all have worked with as part of the national family peer support kind of certification model. So if there's any websites or links that you'd recommend folks take a look at there, feel free to drop those in the chat as well. But very helpful. Oh, yeah, Luke's asking, is there specific use of motivational interviewing and coding tools like the MITI? Any thoughts on that, Karen? We can also take that back.
So there's not, because typically the family peer support specialist works within a team, like a wraparound team or a child and family team, where that occurs as a group. And family peer support has a less informal process of engaging families, but it all begins with that group conversation and group strengths identified and the desired goals of the family.
Thank you, Karen. I appreciate that. Good question, Luke. And Dr. Susan, seeing your question related to provider enrollment in terms of classification, yes, we are developing a specific provider type for peer support services, of which there'll be specialties for our current peer-to-peer recovery specialists, as well as our family peer support specialists, and in the future, what will be our youth peer support specialists as well. So a lot more to come on that front, and as this benefit prepares for our final go live, we'll share a little bit more details of what that process looks like. And thank you for reaching out regarding your enrollment process. We would welcome you, if you don't mind reaching out to our Children's Behavioral Health email address. I would love to connect you with our team and we can take a look at that enrollment as well. So I'll drop that email address, or I can ask someone on my team to drop our Children's Behavioral Health email address in the chat. If you would share a little bit more details of that form, we'd be happy to connect you to the right folks on our provider enrollment side. Great. Dr. Cooper.
Thank you. So I'm Takesha Cooper. I'm the chair of psychiatry at UNR Med and the chief of behavioral health at Renown. I'm a child, adolescent, and adult psychiatrist by training. And I'm really excited to see this come to fruition. When I was in California, we worked with someone, with a family peer support specialist, and we called them parent partners. And they were amazing, and they really were an integral part of our team. It's important for us to think about language, making sure that we have diversity for folks that speak different languages. But they would often, I would invite them into the visit with the family would often want them in the visit with me, or talking about medications and treatment options together. So I'm just thrilled to see this come to Nevada, and I think it's been really effective. So what they've done though is that they would hire. It was an employed position. So I guess I'm curious as to how are we going to support the family peer person? Is this a job for them? Are they getting paid? Are there benefits? Because I do think all of those things are really important. And then they did do a lot of training. So Triple P is one of the programs that they would train, and they would give trainings for groups of parents as well. And that way parents are kind of learning together and hearing from each other. And that's been really effective as well. So just wanted to mention those and ask those questions about employment benefits and who's going to hire these folks, and how do we get them throughout the community for everyone.
Absolutely. Yeah, thank you, Dr. Cooper. Happy to take a first stab at this, and then I saw Karen, you come off mute. I'd love for you to share a little bit more about your family-run organization model here. Firstly, to your point about the embedded model in California, I'm thrilled to hear that was so successful, and I'd love, I don't know, you weren't necessarily offering any additional time, but I'd love to potentially pick your brain on how best we can communicate with our current providers about this new model, right? We really want to help equip our providers to understand, what does family peer support mean, and how can I build this into my understanding of a treatment plan and a child and family team? And I recognize that's going to take some time and getting the messaging right. So would love Dr. Cooper and Karen for maybe us to spend some time together in the months ahead, just to think through if there's any best practices from California that we could draw from there, as we know this is going to be a little bit new for our state, not in terms of the service, but in terms of it being a Medicaid reimbursable service, and having our providers really understand this appropriately is going to be really crucial to that. So that was my first part. Second part, related to employment, absolutely. From an enrollment perspective, I'll share a little bit more, and then I'll have Karen share what that looks like at Nevada PEP. We're building our enrollment to be as flexible as possible to allow family peers to enroll either as part of a very specific organization that does family peer support primarily. So Nevada PEP is a great example of that. We're also developing our enrollment to allow family peers to enroll. It's more of an individual provider that would be embedded within some other clinical model. And so that can look like a range of things, but either way, we of course believe that this is a very crucial role that needs to be compensated, and that folks, this is not a free offer of time. This is a really serious role and responsibility, and we know comes with a lot of emotional challenge as well for these family peer support specialists that have gone through this experience themselves. So we want to honor that and compensate them appropriately for that time. So our reimbursement rates are intended to reflect that. And it's really up to whatever organization they work with in terms of the details of that. So Karen, anything you'd like to add or detail from your model that would be helpful?
Right. You absolutely nailed it. And yeah, we are considered a workforce, and we do not expect anybody to volunteer their time doing this work. It's great work, but it's hard work. So it requires training.
Any other questions or feedback on this piece? Yeah, thank you, Luke, for your feedback on motivational interviewing. I think that's something we can take back, especially as we think about our credentialing, or our certification model and what that can look like, and some sort of endorsement as well. That would be helpful for us to consider. And we'll take a look at that justification from the Mental Health Consortium report as well. Thanks for noting that, Luke. All right, in the interest of time, and we still have another section that I'm excited to share with you all. We'll keep moving, but we really would appreciate your feedback on this policy. We'll share more details on that timeline with you all at our conclusion slide, but we're submitting this for a public hearing in April. So time is of the essence, and we really want to make sure we get this language right. So please send any follow-up thoughts if it comes to you tonight or tomorrow or whenever. Please send those via email to us at that Children's Behavioral Health email address, and we'll be eager to have that conversation with you and happy to set up time to discuss as well. So with that, we're going to shift gears a little bit to our psychiatric residential treatment facilities. So I'm going to breeze through a few overview slides that I think are really important, but in the interest of time, I want to get to our discussion as we have already discussed PRTFs in this forum. So as a reminder, these are intensive behavioral health services offered in a residential setting. These are nationally licensed or licensed by the state of Nevada that meet federal requirements for PRTFs. You may have seen a number of different acronyms here, but PRTF is the federally recognized one at this time. And those facilities are compensated on a per child per day basis. So as we've shared a little bit in our previous discussion on PRTFs, there are a lot of really robust requirements regarding residential treatment in our settlement agreement. So you can see that in section 6, we've called out a few things, but the goals are really intended to reduce unnecessary placements, particularly out-of-state placements, ensure that discharge planning, which is a theme we've heard from you all many times and is really an area that we need to improve here in the state. We need to make sure that discharge planning is smooth and continue and really supports our youth and families in a really challenging time. And we also need to ensure that these standards are being met by collecting and reporting data and independently monitoring these stays. So again, a lot more details in that section 6. But in light of this language in the settlement, we've actually already made some changes to our PRTF policy. And so I know we shared in January a little bit about that public workshop and public hearing. Those changes were actually effective February 26th of this year. At a high level, they align with current federal regulations. They really clarify what it means to provide PRTF level of care. One area of feedback we heard from you all is that there's certain services that may be billed best separately to ensure that youth can get access to the care they need while in a PRTF setting. We've also really thought a little bit more clearly about how can we set a clear expectation for discharge planning for all youth leaving PRTFs. And you'll see that language reflected in our new policy as well. And want to thank you all for your feedback on that point because we know that's really crucial. So that's kind of some tweaks on our policy side, which ensures that in order to receive Medicaid reimbursement, these facilities need to meet these standards that are listed in our Medicaid Services Manual. However, the flip side of that is, how do we pay for this, right? That reimbursement column of our earlier slide. So I've tried to come up with some sort of visual to describe what this looks like, and please forgive me, it's not the most visually beautiful. But what we've developed is a per diem model, meaning a per child per day model of payment that reflects a more standard model that also aligns with the outcomes and access that we're trying to achieve in our state. So once we receive federal approval, all of these rates will be effective January 1st, 2025. And so that will look like an $800 standard base rate. So any youth in a PRTF facility, that facility can bill $800 per child per day. That can actually increase to $950 per day if the youth has complex needs that require additional staffing or sources to support. And so I recognize this is something that we'll dive into a little bit of the data here, but we're really trying to solve an access problem with this. We know that there are many youth who are not able to get this really crucial level of care right now because they require additional support to be successful in that setting. And so as the payer, as Medicaid is a health insurance payer, we have the ability to think about how can we align our payment model and our incentives to help address some of those access concerns. So I'll share a little bit more details about that, but that's really what we're trying to solve with the complexity add-on. That gray box at the top is what I'm excited for this group to provide input. This is the last piece of the puzzle that will actually start next year. But this is really saying we're now trying to solve the quality component of this puzzle, right? Once we've secured access for a youth, how do we ensure that the quality of care they're getting aligns with what we believe is best practices, most aligned with our settlement agreement and the outcomes that we want to see as members of our community, as family members, and as youth across our state. So before we dive into that quality incentive payment, I do want to share a little bit more about that complexity add-on. Again, this was shared at our public workshop back in December and our public hearing as well. So hopefully it's not new news to many people, but I think it's important for you all to see how we're thinking through this before we turn to that quality incentive payment. So I won't talk through the data in the details of, or in the interest of time here, but there's a lot of data that shows youth with complex needs, particularly those with intellectual or developmental disabilities, or youth with a history of aggressive or sexualized behaviors, have a lot of challenge getting access to the care that they need here. And we've heard this loud and clear from many of you on this call, and I'm appreciative of those in particular who have shared data and kind of their experiences. It's heartbreaking when our youth are not able to get the access that they need. And so our goal is really to try to help, we know this is not going to solve all access challenges in our state, but we hope it's one important piece of that puzzle. And so you may be wondering, how is complexity defined? These are the details of what we're really looking at here from a policy perspective, but it's really about demonstrated need for additional services or support. We recognize that can take the shape of many different forms and shapes in terms of what these facilities are looking for or would need to support these youth. And so these are some of the areas that would be included in a justification that would be submitted by the facility for this higher rate. So with that, we're going to turn back to that last piece of the puzzle, which is this quality incentive payment. So this is a little bit of information that we shared with you in that pre-read document. And so happy to answer any questions that you have on this model, but I'm really excited. As we've been designing a quality incentive payment, what this means is if a facility meets a particular threshold, they perform at a certain level that we believe is good, they receive an additional payment added on for as kind of essentially a reward for those efforts. And so what's really crucial here is that we pick the right measure, right? We want to measure the right thing that will get us the outcomes that we want to see. And so we've partnered with a team of data experts at a company called Stellation, who have been spending a lot of time digging into what is our current performance? What do metrics look like in our PRTFs in Nevada today, using available Medicaid claims data and a lot of other information, and thinking about what are some options on the table that we can bring to you all to discuss as potential areas of focus for this quality incentive payment. So with that, I'm excited to turn it over to Michelle, one of our partners at Stellation, who will share a little bit more about the approach and strategies that we're using for the quality incentive payment and a few of the metrics that we look forward to your feedback on today. So Michelle, I'll turn it over to you.
Awesome. Thanks so much, Anne, and thank you everyone for your time and attention today. So in terms of how we're approaching this, a little bit of background on Stellation is we were founded based on PhD work that was done by my co-founder Diana to look at how do we better measure and understand provider quality in a way that better adjusts for patient complexity so that we don't penalize providers who take care of more complex patients, and then also in a way, and also looks at quality in a way that's more patient specific. So then we can look at provider quality specific to certain types of patients, whether that's certain conditions or different levels of complexity, things like that. And so really our mission at Stellation is to use this provider quality insight to really drive better outcomes. And so some of the approach that we're taking today is really looking at all of the available quality frameworks that exist for PRTFs. And I mean, what you see out there is there aren't that many quality frameworks that exist for PRTFs today. So some of what we've done is sort of pull together quality measures that are in adjacent areas, whether that be community care related to BH, inpatient psychiatric hospitals, quality measures, SNF measures as well, for more residential measures, more LTSS measures. And so we've been collating a bunch of these measures together to look at what might be most appropriate for PRTFs. And so then what we've done is review these with other experts in the field. And these are the initial frameworks, initial quality measures that are part of this framework. So we'll be looking at length of stay, of course, as that's an important piece of the settlement and one of the measures that will be tracked there. But we'll also be looking at things like hospital admissions during and after a PRTF stay, ER visits as well, readmissions to the PRTF within 30 days of discharge, as that's something that indicates that potentially this patient was discharged too early, or there wasn't appropriate discharge planning, whatever that might be. We'll look at any violations for licensing, health and safety, and then we'll also be looking at successful transitions back to the community. And so this is meant to be a longer term measure, looking at a 6-month period of time following discharge from the PRTF to check that there isn't a hospital admission, there isn't a readmission back to the PRTF, and that the that youth are able to actually stay in the community following their PRTF stay. So that's the high level. Would love to open it to any comments and questions. And I saw somebody mention something in the chat.
Yeah. No, thank you, Michelle. It's a great overview. I will turn it back to that slide with the list of metrics, but I just want to tee up our questions for discussion. We have about 8 minutes here, and we'd love to get your feedback on given your experience with PRTFs, either as a provider who is referring there or practicing there, or as a family member or a youth that has stayed there, how would you define a successful PRTF stay? And which of these measures do you think help us get to assess whether a PRTF is moving in that direction of providing successful care for the youth in their care? So I'll turn back to this piece and then I'll go on mute, but I would love feedback, any initial thoughts or questions from this group on the quality incentive payment framework and the metrics here that we have on the table to start. Yeah, Becca.
Hi, I'm a director at Sierra Sage Treatment Center, which is a PRTF, but I was also in probation for 13 years before I came here. When I look at successful PRTFs, both from a customer end and from a provider end, I really want to see them not return to PRTF level of care, and so to me that's length of stay. I would rather have a slightly longer length of stay and have them not return to another PRTF. So those measures, length of stay can be hard because you might be a short length of stay, but the kid returns to care very quickly. So, I would definitely look at both of those.
That's great feedback. Thank you,
Hi,
Becca.
this is
Yeah, go ahead.
Hi, this is Matthew. I'm the parent of a foster kid who just had a stay at a PRTF. I'm also a licensed healthcare provider. And while I agree that there are definitely some kids who probably need a longer stay, my other concern has been that I've received a lot of step down cases, and for my own child, just had this experience where, or in terms of what would define a successful stay, I would have preferred to have actually seen a shorter stay that felt less of something that was just taking up a seat from a kid who had higher needs, and one that actually involved a more realistic, more accurate level of evaluation that actually took into account my child's existing treatment team, as opposed to ignoring us for the first 3 days and keeping the kid for the maximum possible stay. I was extremely frustrated with that, and sorry to bring that up in a meeting, but it seemed relevant, and it literally just happened. I just got my kid back the day before yesterday. And that whole process, to me, on this kind of stuff of getting people access, I see a problem there when some of those access seats are taken up by, oh, let's just shuffle a kid over, and then not even very accurately evaluate or take into account any treatment history, just kind of that one size fits all piece. And I know that goes more towards the quality than access per se, but it kind of just ended up, well, we filled a seat for a week, and that seat probably would have been better served by a kid who actually had higher needs for it, if that makes sense.
Absolutely. No, thank you, Matthew. And thank you for sharing. No need to apologize. That's exactly the experience that we appreciate you sharing in this forum, because that's what's the reality of this work. And we want an experience like yours to guide decisions to make it better. So thank you for sharing that. And I will also clarify as well, the length of stay in PRTF is really intended to reflect a shorter length of stay, right? That's aligned with our settlement agreement, which is to decrease the length of stay to a clinically appropriate manner. And that length of stay is really going to be specific to the youth, but to your point, we don't want it to be any longer than it is no longer clinically needed. So we can really try to clarify that in how we talk about the metric. And I think we'll need to spend some more time really fleshing out how do we set a threshold that's appropriate, given that youth are going to need a varying level of care at a PRTF facility. So seeing a lot of hands
I'd
here.
also just like to
Yeah.
throw a quick piece in there. One of the things that I've noticed, at least here in Las Vegas with the various different ones, is that I've seen a dearth of, and this may be a lack of providers, or no lack of providers with the experience, but I've really not seen for all of our autistic and FAS and other kids who sometimes end up with these stays, I've seen a real lack of providers with any kind of ABA therapy training. And that has, for a number of cases I've seen in the diversionary court, been one of the things that actually results in kids going back more frequently, because they seek it out as a vacation, using the kids' own words, because they actually find it too reinforcing to be there.
Yeah, thank you for
which
sharing
defeats
that.
the purpose.
Yep, absolutely, absolutely. And access to ABA services is definitely one of the reasons that we changed that kind of simultaneous billing policy to try to better reflect not all of our PRTFs are equipped to provide ABA in-house, but they can bring in others that can. And so definitely welcome feedback from this group as that is implemented to see if that is kind of helping address at least a part of it, but definitely appreciate you sharing. It's a key challenge. Kim, turn over to you next.
Hi, good afternoon. Kim Abbott from the Children's Attorneys Project at Legal Aid Center of Southern Nevada. First, I'm so grateful for this work to be done around the quality piece of this and around improving performance measures. It's so desperately needed and appreciated. I would just, 2 comments I would make. One is on the criteria that talk about return to the PRTF or readmission to the PRTF. I want to make sure we're tracking return to any PRTF. Because it's not typical that they would return to the same one. That's typically not how it would work. They would return to a different facility a few months later. And so I just want to make sure that we're not losing that in the process somewhere. Similarly with the transition planning, I think it's so important that we have robust transition planning. I think it's going to be critical how that's measured, because we have a lot of facilities now saying they're doing robust transition planning, but saying they're doing it and actually seeing it play out to support the families are 2 very, very, very different things. And so those are just my 2 things I would hope we could pay attention to as we move forward.
Yeah, great feedback. Thank you, Kim. Dr. McGrew.
Yes, thank you. Along similar lines, being a data nerd myself, I'm always interested in like how to collect the data, how to make sure that that's capturing what we actually want, but also avoiding some like inadvertent side effects by where we choose to direct our attention. So the readmissions to PRTFs make me a little bit nervous as a quality measure for a couple of reasons. One, we know we have a provider shortage. So failure to readmit at a PRTF is not necessarily showing value or in terms of like the quality of service. It can just be pointing to that shortage of providers and lack of space. So I would want to lean more into some concrete ways of really getting at that transition back to community, which right now is very vague. What is a successful transition back to community? What does that look like? Instead, what are some things we can actually measure and identify? And I think what we would be looking at is like actual training being delivered to caregivers with respect to like what they need to know in order to make that transition successful, and then actual contacts with outpatient providers that will be providing service after leaving the PRTF, and actually kind of documenting like, okay, these are the service providers we've been in contact with. This is the exchange of information that has happened. This is the plan that's been put in place.
Thank you, Dr. McGrew. That's wonderful feedback, and I'm glad to hear you're a fellow data nerd on this. Absolutely. Number 6 is intentionally quite vague because we're looking for your input on how could we define it, and you gave 2 great examples. So I'm thankful that Michelle and our team is on to document those. We'll note those and try to figure out, given the data available to us, how could that look in terms of measurement? And we do plan to come back to this group with some more specific. So we've now narrowed the list to perhaps 3 metrics that we think are very measurable and aligned with this input as well. So definitely the first of many iterations of this you'll see to come. I will also flag, I know we have about a minute left. I do want to make sure we have time to collect all of and really hear all of the feedback for folks on the call. And I want to respect everyone's time that it is late in an evening. So I will stay on and happy to continue this discussion for as long as folks are available to stay. But for folks that do need to hop right at 5:30, I want to thank you for your time. We will share, again, the materials and takeaways and asks for feedback from you all via email. So you won't miss anything if you do hop off at 5:30, but we'll continue to work through the list to make sure everyone who has input here, we can hear that. So with that, I'll turn over to Jessica.
Hi, thank you. I think that this will kind of piggyback off of the last 2, but I want to acknowledge that sometimes with the best of planning, families may or may not follow through with said planning. And so if there is a way in which we take into account whether or not families are actually going to the services that are put in place for them, on a Medicaid, on a back end, what's being billed after the discharge is taking place. Because if families don't follow through and kids are not getting the service, the chances of them ending up with crises again are very high. And that does not mean that the PRTF did not do its job or that the service did not work. That means that the family system or the system in which that child goes back to or that youth goes back to is maybe not a super supportive system. And so there are a lot of those systems that we see. We see them in child welfare, we see them at mobile crisis, we see them in PRTFs. And that does not mean that the service that we are providing isn't working. And that's important to think about. And then also I am a little bit worried that if a PRTF is not going to be, getting this reimbursement, if they continue to have these kiddos show up at their door, do they deny, potentially like, oh gosh, here we go, we have this kiddo again, and this is going to really skew our numbers. And of course, the hope is that that wouldn't be the case, but that is a reality when we're looking at money. And then also just from a Medicaid perspective, I would ask that Medicaid considers when you are having somebody discharging from a PRTF that we can't wait for the 14 days to wait for a prior authorization for that kiddo to get into the next outpatient service. And so that really also needs to be prioritized, because when we're trying to do those connective services, and sometimes that's true even from a mobile crisis perspective, when we have a kiddo who's in crisis and we're trying to connect them and somebody's doing a prior auth because they've already, used their however many free sessions, and we're just sitting there and the family's like, yeah, they're just waiting for their prior auth, so they can start their sessions. That's a barrier. And so if they're sitting at PRTF and then there's this gap because we're just waiting for the service to be approved from a Medicaid perspective, I would hope that maybe that is also something that can be worked on. Like, we know this kid is in this higher level of care, and that can be something that can be thought about. Not exactly the answer to this question, but definitely something.
No, you just gave us a wealth of feedback. So thank you, Jessica. I really do appreciate it. And I thank you for calling out as well the potential adverse effects of a quality incentive payment, right? This is part of the reality that we're working in, is the incentives don't always drive exactly what we want to see. And we need to think about that ahead of time as a group. So thank you for raising that. And I make sure we'll document each aspect of your feedback as well. And we'll continue to revisit that. Dr. Cooper, I realized I had skipped over your hand initially. I'm sorry about that. I'll turn it over to you now.
That's okay. As I'm thinking about your questions, I'm thinking about what does it take to provide really good care to a patient? And I think back to my days in private practice, and then I think if we think about those things, and then just how do we kind of operationalize that right on a larger scale, I think that would lead to better outcomes. And so one is, making sure a PRTF has a medical director who is a board certified child and adolescent psychiatrist, because that person is the most trained to work with this patient population. I know we don't have enough of them, doing our best to increase the numbers. But I think maybe having, as many board certified child psychiatrists would be great. And then they can work and really kind of teach some of the, APRNs and other folks that are maybe providing additional care, so that they're doing it according to the evidence. Because I see a lot of kids who are just on polypharmacy, and my worry about a short length of stay is that there might be unintentional motivation to medicate kids so that they are sedated or they're not, causing any problems. And it may look like their symptoms are much better, but they're really it's just sedation from the medication. And so it's really important to think about, I think we just need providers that are really well trained to take each child and the system that they're in, really understand what's going on in that system, provide evidence-based treatment, be it medication, be it specific therapy, right? So if a kid has trauma, that needs to be identified in the assessment. And then we need somebody who is well-trained in trauma-focused cognitive behavioral therapy, and that person should be certified. And then we should make sure that they're maintaining their certification so that they're implementing the model to fidelity. Same thing with autism and ABA, same thing with substance use. So, I mean, those are some of the things I'm thinking. And then the other thing that's really important that I don't see a lot of here in Northern Nevada is collateral information, right? Like, it takes a village really to work and to really improve the lives of these kids. And so I'm always telling our child psychiatry fellows, like, call the teacher. Like, how do you know that the child spends 9 hours at school? Like, their teacher really has a lot of input that could be really helpful. So I think the PRTF has to think about that. And those that do that collateral, reaching out to, of course, parents, but others that are involved in that child's life, really provide the holistic approach to what the challenges are. And when the child is ready for discharge, those people in the village know kind of, what they need to do to maintain improvement. I think the school is another really important piece. The parent partners would go with parents to the IEP meetings and really just provide support for them. And so, like, thinking like really holistically, and then how do you kind of create measures to look at those things would be, I think, really good for care. So those are just some of my thoughts kind of offhand.
No, thank you, Dr. Cooper. I appreciate, as always, you raising the provider workforce need, not only ensuring we have enough, but really high quality, well-trained providers to support this particular population. So love the idea of thinking about this quality incentive payment as another way to kind of align incentives towards that overarching goal, and appreciate, all aspects of that. So I'll keep moving, but thank you for that. Really helpful. Miambi, we'll turn over to you.
Thank you. So I wanted to add on to Ms. Abbott's comment regarding performance measure number 4, where we're looking at readmissions to the PRTF within 30 days of discharge. I just wanted to emphasize the importance of really looking at whether recipients are not just discharging to the facilities that they just, that they previously received treatment from, but any PRTF. For us who's working with youth that are system involved in child welfare or JJ, we have a lot of youth that are negatively discharging from these facilities. And then they're lingering either in detention setting, correctional settings, or they're lingering in child welfare shelters. And sometimes we're looking for another PRTF, which is the level of care they need, for even another 60 or 90 days. So sometimes, unfortunately, even longer. So I would recommend that we look at it from a recipient kind of perspective and see if they're discharging to any PRTF within the next 60 to 120 days.
That's a great point. I really appreciate that. And we will be tracking a lot of multi-system involvement in our data. And I think that's a great way for us to think about aligning that with this quality incentive payment. So thank you. We appreciate that. Gwyneth?
Hi, everybody. Gwyneth Smith. I'm with the Clark County DA's office. First, I want to say I just really appreciate the thoughtfulness of the conversation and kind of the pros and cons on all sides, and that we're having this discussion now. Because I can see unintended consequences happening. So I'm really grateful to be part of it. Number 2, Miambi took the words out of my mouth. One of my comments was going to be that tracking a 30-day period, I do not think is sufficient, just knowing these cases. I think it needs to be like at least 60 days or potentially more to really see that a discharge is successful and that it's sticking. My second comment was going to be, and I don't even know if this is an idea that can be implemented, but I want to share it. In terms of successful discharges, is there a way to incentivize financially PRTFs to establish kind of formal partnerships with these step-down community level services that are needed on the back end for a successful discharge, so that you're really like formalizing that continuum of care that we lack in Nevada? So maybe that's a PRTF that decides it's going to develop its own level of service that's at that community level, or partnering in a formal way with other agencies in the community, so that when a child is discharging, you're not just measuring was a referral made, right? Because that's where we know the gap exists, but that there is a formal handoff with a formal mechanism for the lower level of care to communicate with the higher level of care and really like collaborate pre-discharge. So
glad to see a lot of thumbs up and claps. Gwyneth, I absolutely agree. I think that thinking about transitions back to the community, not only as a family or kind of home-based effort, but also a provider-to-provider effort, right? And thinking about how do we really formalize that. Let us take it back and think about how we could think about carving that a little bit more explicitly as an expectation of essentially care transition in a really meaningful way. And I do think you'll see, to Beth's earlier point in the chat, there's a lot of good language about discharge coordination and the settlement. It's clear there's a lot we need to dig into here, and this is just one aspect where we could kind of reinforce that with the incentive. So thank you there. Yeah, Dr. Susan.
I wish I could clap multiple times. That was amazing. I felt like she touched some points. I appreciate everyone for everything they're saying. I've heard so much of the things I had in mind. But one thing I just want us to always remember, like the transitioning, if we want to transition and the other person on the other side, sorry, I'm with Zane Medical. So I'm a clinical director for Zane Medical. So I just always want us to always remember there's a lot of people in the community that do not want to work with Medicaid. So now we are first existing with a shortage already in Nevada. So if we don't have these providers that are ready to take outpatients, to take this kids outpatient, then we have a problem. So there should be a way that we work with the community. Say Medicaid, like if you want to incentive, you don't have to be monetary. You should just come out and say, hey, I see what you do. We appreciate what you do. We want to encourage and see which way we can support the community to have more people either have more practices or more PRTFs out there and all that. But a lot of people don't want to have these interactions with Medicaid because the fear of any clinical issues can get you in trouble with Medicaid. Let's be honest. So you need to be on your game all the time. But the community is suffering from that aspect of the fact that, hey, I don't want to be out here and giving my heart out to the community and serving the community. And I find myself in trouble doing that. So I'd rather not deal with that. But we need these providers. We don't even have enough of them. So I feel like there should be a way that there should be connection between Medicaid and the community to make sure we encourage more people to take the training, to get the ones that already have the training to offer their services to the community. So I feel like that'll be a very nice way for us to increase the population to make the transition very smooth. Thank you.
Yeah, thank you, Dr. Susan. So many good themes here of how can we think about not only incentivizing our current providers, but using this as an opportunity to think about really building a robust and well-equipped array of providers to support our youth at all levels of care. And so I want to thank you for the care that you're providing in the community and looking forward to all of your feedback as we continue to develop this and really hone that. Let us take it back on the provider workforce side. I think a lot of good feedback for exploring that as a particular metric here. So thank you. And Becca.
Hi, so when I was a placement supervisor in California, we put kids in programs like these, monitored them. But one of the things that we did is we surveyed our youth at 17, 19, 21, and 23. And so we would track them down. Now on the government end of things, we could use LexisNexis. We could search databases to find the kid's last address and all those things, to reach out to them and do a survey for their well-being. We'd give them gift cards. But it really does have to be a government agency tracking those outcomes because they're the ones that have access to finding the children. But we tracked, and they still do track, those outcomes at 17, 19, 21, and 23, check for new arrests, check for, talk to them about their mental health and how they're doing. And that gave a really robust set of data for us to look at, but it had to be collected on the government level. It couldn't, so it's not something the providers have access to. So just, you know, it would be awesome if Nevada would do something similar so we could all see the outcomes for our kids and where we need to improve it. We've really utilized also too when we have kids that we're stuck with where the social worker, the people aren't planning their discharge appropriately, we've submitted them to the state committee and gotten really good services that way for the kids too. Because believe it or not, you get really stuck sometimes with the parents and the social workers not wanting their kid back, not willing to do effort. And so that state process has actually really helped a lot of the kids too. So making maybe that more highlighted for providers to know that there's that route to get help when people are just trying to warehouse their kid on you.
Absolutely. No, thank you for sharing, Becca. And the idea of a longitudinal study like that is really exciting. And something I think we should consider or think about what that would take to implement here. I'm sure a lot of really good gems of information we could find from that. So thank you for sharing that. That's really helpful. And Carly, turn it over to you.
Thank you. I just wanted to share one thing that we see a lot working with families who have had a youth discharged from PRTFs is that, you know, when services aren't available, when there are long wait list, parents are sent home with a list of providers and a list of calls and a list of things to do, where they're then, you know, solely responsible for taking care of the kid who a lot of times is still having these issues, while also being the care coordinator, while trying to get them to school, while trying to work their own job because they still have to provide for their family. And my hope is that with this package of services, that through the care coordination, the family peer support, and all of those things, that the families will have the support they need to be able to take their kid back home and be successful.
Absolutely. No, I really appreciate that, Carly, and I couldn't agree more. I think the settlement does a great job of setting that as the minimum bar, right? It is not the parent's responsibility to be the care coordinator, nor should it be, right? It's their responsibility to find a way to parent in a really challenging time. And so finding more support for that care coordination role is crucial as part of that care coordination model you'll see really outlined in the settlement. And I'm looking forward to discussing that with this group to get feedback on what can that actually tangibly look like in a way that can best support our families and youth in that transition period. So thank you for raising. All right, with that, I want to thank you all who have stayed on late. I know that we are well over time. This has been a wonderful discussion and just really helped ground me in the different ways that we can think about designing this program. So we'll look forward to further conversation in this forum about kind of our next turn of the crank of what these metrics can look like. And as if you have thoughts on this topic that come to you, as always, please don't hesitate to reach out over email. We will be continuing to work on this. We have weekly meetings internally about what this looks like, if not more frequent. So excited to incorporate all of this feedback in the weeks to come and a lot more here. So with that, we'll wrap up briefly. Takeaways here as a reminder, working group representatives, please do submit your nominations via email. For a co-chair, again, those can be yourself or a peer in the list. We really look forward to working with you and thank you for your consideration of that. And for all attendees, we'd appreciate your feedback on our family peer support policy. If there's anything else that comes to you after today's conversation, please don't hesitate to reach out over email. As a reminder, that Monday 17th deadline, March 17th deadline is coming up quickly. So thank you in advance for any feedback you all have at that time. And if it comes afterwards, we still want to hear it and we will be continuing to improve this over time. So I appreciate your thoughtful feedback and we look forward to seeing you at our April meeting on Thursday, April 10th at 4:30. So with that, I'll open up for a final opportunity for public comment. As a reminder, no action may be taken upon a matter raised in this comment period unless it was on the agenda, and comments will be limited to 3 minutes per person. So please state your name for the record and feel free to raise your hand if there's anything you'd like to add here. Yeah, Becca.
Sorry, this is Rebecca Graham for the record. I just wanted to indicate that I shared the community care coordination resource in the chat. It's incredibly helpful when you're trying to organize the services for aftercare.
Well, thank you for sharing, Becca. Thank you. Any others? All right. Well, with that, we will adjourn our meeting. Thank you again for your time and your extra time on this evening. I hope you have a lovely rest of your week, and we look forward to seeing you in April. So thank you again.